Well, good morning, everyone, and thank you so much for joining us for this morning's webinar presented by MSNY with collaboration of CMS. We're so happy that you could make it today and learn about the No Surprise Act. So I'm going to go ahead and just do some introductions, and how this is going to work is we're going to have the presentations by a couple of individuals from CMS that we're so very grateful for the collaboration. And once we're done with the slides, the presentations, we're going to go ahead and then take some questions. I surmise that the presentations will probably be around 20 minutes or so, and then we will take questions in the chat. If you could just either raise your hand or type the question, and we'll go ahead and do that. And then if we get done before an hour is up, we'll give you back some time, and we'll go from there. So we'll go ahead and start. And my name is Heather. For those of you that don't know me, my name is Heather Lopez, and I'm the Director of Physician Payment and Practice with the Medical Society of the State of New York. We also call ourselves MSNY for short. For those of you that may not know, MSNY is the only professional association representing all physicians in New York State. We provide access to practical resources and a strong community of professional peers. By being the voice of physicians in New York, we promote quality, accessible, and affordable physician-led healthcare. We help you connect, engage, influence, and learn. If you or your physician is not already a member, I encourage you to join. I did ask those questions when you did register. So if you did click yes, we'll have somebody reach out to you to give you more information. If you accidentally click no, just shoot me an email and I'll be sure to get back to you. We know how little free time everyone has in your day. So with that in mind, today's presentation will probably be about 20 minutes. After that, we'll take a few questions. You can post your questions in the chat, like I mentioned earlier, or raise your hand if your question's kind of long. And we will answer as many as we can get to by the end of the hour. MSNY works with many partners who have been carefully vetted on our behalf. Today, we're providing a webinar in collaboration with our friends at CMS and also for Center for Consumer Information and Insurance Oversight within CMS. So today's presentations, as you know, is entitled Spoil the No Surprise Act webinar. Get ready to learn, because today we're going to be covering No Surprise Act that we all are very aware of, frustrated with, confused with, but CMS is going to provide some clarity for us, which I'm super excited and grateful for. The steps and processes, as well as clarifications. But let's get to it. Let me introduce you to Aideen Zephyrin. She has over 15 years experience within CMS, specializing as an outreach specialist in Region 2. She brings vast knowledge in many of CMS programs. In addition, we have Deborah Bryant, who serves as a senior advisor in the Consumer Support Group, providing policy and strategic leadership for expanding consumer protection in private healthcare insurance market. We also have Dara Abrahams, who is a health insurance specialist with Consumer Support Group. Her focus is on the NSA state federal deeming process, federal IDR process, and inquiries. She also provides training and resources for marketplace enrollment assisters who help consumers better understand their healthcare coverage and rights. We also have Jeannie Ann, who's a health insurance specialist as well with the Consumer Support Group. She oversees outreach on the No Surprise Act to various stakeholder groups and maintains the No Surprise Act website. So thanks again for joining us. We're really excited for you to be here to be able to offer this to you. And I'll go ahead and turn it over to Aideen for now.
Thank you, Heather. Good morning, everyone. As Heather says, time is of the essence. Since you already introduced me, I'm going to go ahead and start right away. I'm going to share my screen right now. Hold on 1 second, please. Okay, so as you know, the No Surprises Act is vast. So today we're going to be focusing on the federal IDR process, the Independent Dispute Resolution. So it's going to be an overview of that, since it seems to be the most, well, one of the most frustrating parts of the new law for physicians.
Hi, Dean, this is Jean Ann. I'm so sorry to interrupt, but could you
Please.
maximize your screen? It looks really tiny on our screen.
Oh, is it? Okay,
Yeah.
one moment, please.
Thank you so much.
Is that better?
Yes, perfect. Thank you.
Okay, great. This is our legal disclaimer. It basically says whatever we're going to be discussing right now, it's not the full extent of the law, and we definitely encourage you to look at the laws, regulations, and applicable statutes at your leisure if you wish. So what was the need of the No Surprises Act itself? It's literally based on surprise medical bills that patients receive from out-of-network providers at in-network facilities. So it's in 2016, for instance, we had almost 43% of emergency department visits at in-network facilities that resulted in out-of-network bill of about 628. That's obviously an average bill. We have states that includes New York that enacted laws to reduce or eliminate the balance billing. But because it's a patchwork of work for consumer protections, because each state has their own version of laws. So the federal No Surprises Act is trying to make sure that we all are on the same page. So the No Surprises Act, it protects individuals from surprise medical bills for emergency services, for air ambulance services, not ground ambulance, air ambulance services by out-of-network providers, and also non-emergency services provided by out-of-network providers at in-network facilities. It established the Independent Dispute Resolution, the federal IDR process, which we're going to be talking mostly about today. It also requires providers to give healthcare cost estimate to uninsured patients. I'm sure some of you might have heard of the good faith estimate. That's what we mean by that, and other consumer protections. The law became effective in January of this year, and it applies to items and services, to your patients enrolled in private and commercial health coverage. The ones also enrolled in employment-based group health plans, individual and group health plans, the federal health plans, non-federal government plans, and certain church plans within IRS jurisdiction. Also covered student health insurance coverage. Some requirements also apply to providers and facilities with respect to people who don't have a healthcare coverage. So one of the requirements, for instance, is that they are provided a good faith estimate for scheduled care, not for emergency care, scheduled care. I should mention that your patients who have Medicare, TRICARE, and the Indian Health Services, the No Surprises Act don't apply to those beneficiaries. because those programs already have protections against high medical billing and no surprise and surprise medical billing. So if you have patients that have Medicare, Medicaid, IHS, the VA, also called the TRICARE, those patients, the No Surprises Act don't apply to them. So this is a quick overview of the No Surprises Act prohibitions on balanced billing. So it requires health plans. From now on, whenever you hear me talk about the plan, I mean health plans in general. So the No Surprises Act requires health plans to apply in-network cost sharing if it's higher than that, that would be applied, and prohibits out-of-network providers from billing individuals more than they would have been paying were they in network. So that's pretty much all it means. It means that the patient comes in and they receive services at an in-network facility, but there happen to be providers who are out of network. The NSA prohibits the providers that are who are out of network from billing those patients more than they would have billed if they were in network. In limited situations, it allows out-of-network providers and facilities to seek written consent. And it's important that that I stress the word limited situations. So for instance, in emergency situations, the written consent would not apply. So when the patients, for providers that are out of network, when the patient goes to that facility that's in network, the patient will be required to pay only the in-network cost sharing. So we all know about deductible, copay, co-insurance, and so on. When they receive services at those facilities, they would obviously receive billing, and that would fall under those three categories: deductible, copay, co-insurance. So the NSA is saying that the patients will be receiving the same bill as if those providers were in network. That's pretty much the gist of it. So the even though you are out of network, when you bill the patient, you'll only be billing them for what they would be paying were you in network. Now, this is the part where the health plans, they have to pay the out-of-network provider or the facility an amount that's in accordance with what we call the all-payer model agreement, or whichever is specified by the state law. So since we're in New York, by the New York law, if it's applicable. Now, if that doesn't exist, this is the part they would have to deny. They can make an initial payment, or they can do a denial of payment, and all that has to be done within 30 calendar days. We're going to be talking about the federal IDR process itself. So what is the federal IDR process? That process has been established because it's for providers that are out of network. And when they receive their payment from the plans, from the health plans, and they don't approve that payment. So that's the bottom line of what the federal IDR process is. So what are those? We're going to be talking more about that in a few moments. But for now, keep in mind that is the whole point. You out of network providers who don't agree with what the health plans are paying them, then they would be going to a federal IDR process, basically to argue their case that they should get paid a different amount than they have received. And that we would be coming in, when I say we, I mean the federal IDR process would be coming in if there is no state IDR process, or what we call the all-payer model agreement. So if they don't apply, then the federal IDR process would be the one determining what the out-of-network rate is for emergency services, for certain non-emergency items and services, and of course for air ambulance. So some states, not all of them, some states provide a method for determining the total amount payable. New York, for instance, is a state that provides a method for determining the total amount payable by a plan to you, the out-of-network provider. The No Surprises Act recognizes that the all-payer model agreement under that section of the Social Security Act provides a state-approved amounts for out-of-network items and services as well. If the all-payer model agreement or the specific state law itself for determining it, as I said before, this is when the federal IDR process would be coming in. But if they are available, the federal IDR process will not be available to disputing parties if the all-payer model agreement or the state law itself provides a method for determining the amount payable to you, the out-of-network provider. We have some more, we have a link that we can provide you later. Those slides that I'm going over will be shared with Heather, so Heather can share that with you afterward.
Thanks, Edine. Also, just to piggyback off that, this meeting is recorded, so we're probably going to have that. I'm going to try my best to have it up on the website by day's end, and I'll also have a link that has the slides with that. So thank you, Edine.
Absolutely, Heather. The steps before the federal IDR process itself. So to start, remember that it's an item or service. So basically you send a bill that results in for emergency item services or for the out-of-network provider. Also for non-emergency items or services, and obviously the air ambulance. So that's how it starts. You send a bill because you're an out-of-network provider. If you are in network, nothing that I'm going to be covering pertains to you. So you're an out-of-network provider, you send a bill. Within 30 days, the plan has to submit either an initial payment or a notice of denial of payment, one or the other. Within 30 days, you have to receive that. And an open negotiation period must be initiated also within 30 days, beginning on the day that you, the out-of-network provider, received either the initial payment and you don't agree with it, or a notice of denial of payment. So those are the steps. This is what's happening before we talk about the IDR process itself. And the open negotiation period, which you can see. The QPA, also called the qualifying payment amount, is itself pretty much take the median of the contracted rates recognized by the plan. And one second, please. There's a link that I can share for that. Find it. Jean Ann, you said you could put it on the chat for me? Okay.
I will, yes.
Okay. One moment. Okay, so the qualifying payment amount, again, the QPA is very complex. We can actually have a whole meeting just about it. But to simplify, the QPA is based on the median contracted rates recognized by the health plan and CSIO, presented by Jean right now. It has created a detailed presentation on the QPA, and that can be found on the No Surprises Act IDR playlist on YouTube. So to facilitate the communication between the parties, and from now on, whenever I say parties, I mean you, the out-of-network provider, and the health plan. That's what I mean. So to facilitate communication between the parties, the departments, and when I say departments, I mean us, Health and Human Services, Department of Labor, and Treasury. So they have issued a standard notice that the parties must use to satisfy the open negotiation notice requirement. So that is, I just covered the steps that precede the federal IDR process. There is a standard notice that has to be used, and the department issued that. That also, this is what it looks like. When you get a chance, you can click on the link and you'll see further what are the requirements. So the federal IDR process itself has 6 steps. Step 1 is within 4 business days, either party. What that means is either you, the out-of-network provider, or the health plan can initiate that process by submitting that notice of IDR initiation to the other party and to the departments. That's within 4 business days. So you submit it to the IDR initiation process, the department, what we call a notice of IDR initiation. Within 6 business days after the initiation, that's when there will be a selection of a certified IDR entity. The non-initiating party, because again, we've got 2 parties, one of them says we're going to go to the federal IDR process. The non-initiating party can accept the initiating party's preferred certified IDR entity, or they can object and propose another one. There are certified IDR entities. One of them has to be chosen. The initiating party can come in and says, this is the IDR entity that I've chosen. The non-initiating party can say yes, or they can say no and propose another one. So quickly, a lack of response from the non-initiating party within 3 days will be deemed as accepted. So this is a case of you don't answer, we will take that as a yes. One moment, please. Step 3 to 6. After that, also within 3 business days, after a certified IDR entity has been selected, we got 3 business days for the IDR entity to submit an attestation that it doesn't have a conflict of interest. and determine that the federal DIA process is applicable. So within 3 business days, you chosen that entity has to tell you there is no conflict of interest, and they also have to determine to say, yes, the federal IDR process is applicable in this case or those cases for services and items. 10 business days after that selection. That's the part where the parties must submit their offers no later than 10 days after the certified IDR entity has determined that the process is applicable. So each party must pay the certified IDR entity fee, and we go to the next step. Within 30 days, the certified IDR entity has 30 days after its date of selection to determine the payment amount, notify the parties. I know I'm going fast, but we're going to talk a little bit more further down. So 30 days, the IDR entity has to determine the amount, notify the parties and the departments, the 3 that I've mentioned, us, HHS, labor and treasury. And after that, payments between the parties and the amount of refund of the certified IDR entity and so on. We're going to move on because, as I said, we will talk about that in more details. The disputing parties may continue negotiation after the IDR process is initiated. So what that means is the health plans and the out-of-network provider are negotiating. And then they initiate the federal IDR process. All that means is that even though it's been initiated, you've received we've selected an IDR entity, they can still negotiate on the side, both parties, they can still do that. Now, if negotiations are successful, the agreed upon amount will be treated as the out-of-network rate and will be treated as resolving the dispute. So if you can come into a successful, for both parties, of course, successful agreement while you're negotiating, both of you are negotiating on your own, that is fine. You can do that. Once that payment is submitted, that payment is considered the out-of-network rate, and that resolves the dispute. If that happened, the initiating party must notify the departments, the 3 departments, and the certified IDR entity by email, and include a document that basically says this is the agreed upon out-of-network payment amount and allocation of how the parties agree to pay the certified. Yes.
Put my name down. Dr. Goldberg.
Oh, if everybody can put their computers or phones on mute, please. Seems there's a conversation coming through.
Mhm.
Hey,
So-
David, there's a question that keeps coming up, so I figured I would go ahead and pose it. It's in regards to the process. There seems to be a lot of people that are familiar with the processes, but the question is, you know, why is it, what to do when it's taking so long? The process is taking about 115 days. And the actual IDR process and the extraordinary backlog of claims. So that is, it seems to be a couple of people have asked this question. So I don't know if we have an answer that can provide them with what to do and when that happens.
I see. Okay. One of the CSIRO experts will definitely cover that.
Okay.
We can just quickly finish this.
Okay. Yeah,
Yeah.
just in lieu of time, we're running on 8 o'clock. So just wanted to.
I understand.
Excellent.
So where was I? Okay, so the disputing parties, again, allegation of how the parties agree to pay the certified IDR, and of course, signatures. The administration fee, because each party must pay an administration fee to participate in the federal IDR process. And I do mean each party, both the health plans and the out-of-network providers. The administrative fees will not be refunded even if the parties reach an agreement before, on their own, before the certified IDR entity makes a determination. Okay, since we're short in time, basically this is talking about the certified IDR entity fee. It must be within a predetermined range. They're going to hold on to the payments until a determination is made. It must split the fee evenly in case of batch determinations, and so on. Now there is an amount that's being shown here, but let's not worry about that. When you go through it, you will know exactly how much you should be paying. So notice of offer. So each party has to do a notice of offer within 10 business days. So I'm going through that and I'm giving you days. And of course, I know in your mind you're going, but that's not what's been happening. I understand that. The offer of the out-of-network rate is a percentage of the QPA, for batch qualified IDR items and service. They have different QPAs. The certified IDR entity may request additional information. You can batch your claims and use that and do that as a whole. So instead of filing each case separately to the IDR process, you can batch a bunch of claims, bundle them, and then go through the IDR process for all of them. If one party doesn't submit an offer by the time both offers are required, the IDR entity will accept the other party's offer and proceed to make a payment based on that. The IDR entity, they have to consider the QPAs for the applicable year, because of course each year will have their own information, and they also can and will accept any credible information. So what do we mean by credible information? The IDR entity will make that determinations. There are some prohibited factors. They cannot consider usual and customary charges. For instance, they also should not consider amount that would have been billed if the NSA did not apply, and payment and reimbursement furnished by the provider by a public payer. What do we call a public payer? For instance, Medicare, Medicaid, and so on. So those are prohibited factors for the IDR entity. There have been some updates last year in July and October of 2021. Going to cover that right now. They've been finalized. One of the things that been finalized is the definition of the term down code. So down code means any alteration that a plan made to a service code that you submitted and change it to a different service code, and that service code has a lower QPA than the one that you build. So this is a term that has been defined in one of the final rules. Also, the final rules require that that the plans disclose the QPA for each item when they provide that initial payment or denial of payment. They have to disclose the QPA for each item or service. In October, the rule required that the certified IDR entity select the closest amount to the QPA. Now, keep in mind that this was vacated by a federal district court, so because of that, the final rule said the IDR entities must consider the QPA and any other additional information submitted by each party to determine the amount, the final amount. One of the things that also the final rules talked about is what we call a double counting information, also goes with. Double counting only means just that. The IDR entity is going to have information, evidence that he's going to go through to make that determination. Now, because the entity can require, can receive additional information from both parties, this is basically saying do not count certain information more than once. You already have the information. Don't try to avoid counting that information if it's submitted by one of the parties. Another thing that the final rules is mentioning is ghost weights, and ghost weight is basically just that. It means that when the plans are making the calculation, they cannot include $0 rates for items and services, either because it's unlikely that the provider would bill for it, or also when the agreement was being made, the contractor being made, certain items and services was $0. So they should not include that. They're considered the ghost rate. So double counting and ghost rates, it's a no-no. We have a tons of materials for you. There's even a checklist that the departments, all three, they have issued, and this is called the NSA Issue Requirements Checklist. It's on our website, cms.gov, and it's a great tool if you're trying to figure out what should the plans give you when they first either pay you or give you a denial of payment. What that checklist would help answer that question. Your complaint can go to cms.gov. There is a no surprises help desk at that number. It's available for you anytime. If you have questions and you need the answer right away, our website is there, and also the help desk is there. No later.
Adine, I'm sorry, this is Jean Ann. I apologize for
Go ahead,
interrupting.
please.
I just wanted to say that based on the questions in the chat, it seems like a lot of the people on the call have an understanding of the process, and it might be a good use of our time to go ahead and get to their questions.
Oh, definitely. Absolutely. We can do that. Okay, then let's go ahead and take the
So,
questions.
I have, I've got the questions, all down here. So we'll start one. This is from William. For scheduled services, if we provide a good fit, and if these have been answered, just let me know and we'll move on to the next one. If we provide a good faith estimate to the patient in advance of the service based on local reimbursement rates, can we bill the patient for any difference not covered by an out-of-network payer? Has that been answered yet?
Yes, I answered that in the chat, and generally speaking, patients are, it's prohibited to balance bill except for certain non-emergency circumstances where the appropriate notice and consent forms have been given. I'm going to say certain because it's very specific, but never in an emergency situation.
Okay, and you provided those links.
Yeah, I did
Okay.
provide a link.
Okay, great.
Can I jump in with a question to follow up on that?
Who's speaking?
It's Jamal Rahman at Mount Sinai.
Sure.
Yeah, so if you provide a notice of consent for an out-of-network provider doing an elective non-emergency procedure at an in-network facility, and you submit the charges and you've notified the insurance company that this is not a surprise bill because of, and you provide them evidence of the notice of consent. And notwithstanding, the insurance company continues to inappropriately process the claim as a surprise bill, and you try to have them reprocess the claim and you have no response after 60 days, 90 days, and they continue to stall. What's your recourse for addressing this? Does the CMS have some form of portal for us to access these complaints? Or do we, if it's a ERISA plan, if it's commercial, should we go to the DFS since it's a New York State regulated plan?
We do have a complaint process. So I do want to just step back a little bit. I don't think we got to the slide, but in New York, the IDR process applies for the federal IDR process for self-funded plans and out-of-network air ambulance services. All other IDR claims would be subject to New York law. And I did put those links in the chat. I'm happy to put those in again.
This is not an emergency. This is an elective procedure. So this has nothing to do with the IDR. This is an inappropriate processing of an elective procedure as a surprise bill when it's not a surprise bill because the notice of consent was obtained.
So I can jump in here and
I'm having the same exact issue, so I completely agree with him. They're not processing the claims, reprocessing the claims with out of network. We do have the waiver on file for each claim, and we're going around in circles. Like they're elective procedures. The patients are aware that the doctor's an out of network provider, and they're signing the waivers. I'm even submitting the actual claim with the waiver, and they see it and they say, okay, we're going to reprocess, and then they don't. And I have patients that had surgery in January and they're still not reprocessing the claim. And I mean, it's obvious they're just refusing to use the patient's out of network benefits. That's not why this law was made. It was specific for surprise billing. This is not surprise billing. This is a patient seeing an out of network provider, choosing to see them and being aware that they are. So this is the biggest problem I'm having. We're spinning our wheels and going around in circles for the whole year, and no one seems to care. Like none of the insurance companies are taking it seriously or processing.
can
I
I
don't
jump
think
in
no one
from
seems to care. And this is the group that we need to understand who we're talking to here. This is not the insurance companies. So what I would ask for all of you that just said, yes, I agree. Yes, I have the same issue. That's why I'm here. Okay, this is my role in MSSNY. I help you guys fight the insurance companies and deal with issues like this. So what I please ask for you guys to do is anyone that is having that exact same situation that Wilma and Doctor just brought up, if you could just send me the insurance company, the actual plans that you guys are dealing with this specifically to, and then I'm going to work with a dean to figure out, okay, now we've identified what the systematic issue is and what is our best recourse to fix this. Okay, so this is good conversation, and I appreciate that you guys are bringing this up, and it seems to be that we're having the same issue here. So I need to know about this stuff. So if you could just email me, I'm going to put my email in the chat. So if you guys can just email me the practice name, the doctor's name, the NPI number, as well as the insurance company plan. Okay. And if you have an example, a claim number, that would be awesome too. So at least
I can send you, it's
have
across the board.
examples.
It's across the board. It's every insurance company. Not 100%, but I'd say 60 to 80% are defaulting to a surprise bill, even after they've been notified and they've received, and we have documented receipt of the notice of consent. So it's a pervasive pattern that we're observing, and we'll be happy to give you all the claims.
Oh, I don't need all of them. I just need to know for each insurance companies, just an example, and that way we can have this discussion and say, with insurance companies, and I'd like to talk to a dean offline. to figure out what the best action is now. Because remember, this is new, this happened 1/1. I don't think that the insurance companies, clearly have their processes under wrap. And if I could provide them exact details, that's going to show them where the process is broken, then that is exactly what I will do. And hopefully we can, it's not going to happen overnight. We all know that, but with exact examples, they can follow in the system and hopefully be able to rectify this. So go ahead and send me that. I'll put my email address in the links in the chat right now. And then, so moving on to the next questions, because I know that we're running out of time. Oh, doctor, do you have anything else to say? Or was that part it?
Yeah, that's the main point, and I'll
Okay.
send you one example for
Okay,
each insurance
excellent.
company, commercial as well as ERISA.
Excellent. Thank you. Margaret, C, if the provider is not in network, how will they know the in-network charge? Has that question been answered? Has that question been answered?
Can you ask the question again?
Yep, yep. If the provider is not in the network, how will they know the in-network charge?
So I'm not sure.
Margaret, do you want to provide some clarity on that? Is Margaret
That's actually
still on?
not my question. My question was one you asked before that, so I think you flip-flopped them. I think that
Oh.
was William's question.
Okay. Okay, so Margaret, your question's done. William, do you want to provide a little bit more clarity on that question?
Yeah, I would just re-ask it. So if I'm not an in-network provider, how am I going to know what the rate is to bill?
So you would, can you hear me okay? Sorry.
Yes.
You would bill, your charge, and in response, the planner issuer would provide the qualifying payment amount, which is the median in network rate.
How will I know that?
The plans and issuers are required to include it with the payment remittance. So it should be on your explanation of payment, or whatever sort of EOB that is provided by the planner issuer.
So if I don't par with Aetna, say, for example, I have to get a list of allowable charges from Aetna so I know what to bill?
No, you don't have to get a list, so you know it's a bill. You would bill what you believe is your reasonable rate, and Aetna would reimburse you and provide the QPA along with the reimbursement.
So just bill as normal my self-pay rate.
Right.
And I think that answers, Heather, you put that question to me twice before, so maybe this is not the only person who has that question. So hopefully that answers everybody who had that question, that your billing as you've always billed.
As a self-pay.
As an out-of-network provider, right? You're billing as you've always billed. The plan will be sending you that initial payment or a denial of payment, but with that, we'll also give you, as Deb just said, we'll give you that QPA information because they're required to do that.
Okay, so everything the same. We're just not supposed to be balance billing.
I'm sorry, say that again?
So everything is the same as we were doing before. It's just we're no longer allowed to balance bill a patient.
That is correct. Yes. Yes.
Got it. Thank you.
So this question is from Jerry, and if these questions have been answered, just let me know, because I've been taking them along the way that during the meeting. Each time we submit a good faith negotiation, we never get a response, or they are not willing to negotiate. Why is this? Also, when we submit a full federal IDR to CMS for review, we still have no response to ones we have sent approximately 3 months or more ago. The federal IDR email never responds in less than 30+ days. These are issues with no resolution.
So I'm hearing two questions. So maybe we can take it one at a time. The first question was about, if you could repeat that, Heather? 'cause
Yep,
it's
it's each time we submit a good faith negotiation, we never get a response or they are not willing to negotiate. Why is this?
So by they mean the patients?
Jerry, do you want to elaborate a little bit on that?
Maybe I can help, Heather. I think I understand the question. I think they're asking about the plan. So there is a requirement that the provider or the planner or whomever believes that the payment rate is not the appropriate rate, file a notice of open negotiation and exhaust a 30-day open negotiation period. There is no requirement that the other party respond. However, as we put out in guidance and provided in a lot of technical assistance directly with plans, you can be assured that our intent in writing the rules was that a good faith negotiation would occur and both parties would engage during that period. We've heard sort of complaints on both sides regarding sort of some of the hiccups in that process that is causing, I guess, parties not to respond and not to communicate during that time. And we are taking that under consideration. But we have been doing a lot of technical assistance on our side to encourage the response from payers. What we hear from payers a lot is that when they receive the notice of open negotiation, they can't identify the claim. And so we encourage providers to provide additional information. I know there's no requirement to use a form or a planner issuer's personalized form. I saw this question in the chat, so I'll try to address it here now. Only the standard open negotiation form is required. However, based on different payer systems, sometimes they need additional information to help identify the claim. So we encourage providers to be responsive and give the payers what they need to identify the claims during those 30 days. But we are considering ways in which we can encourage more communication during that 30 business day open negotiation period. So I want to acknowledge that we hear you. And that was just the first question, I think. The second question.
Yep. So we have 8 minutes left of the meeting. So
I know what it was, and it was a question that came up about the time and how long it takes to process once the
yes,
federal IDR process.
that's the federal IDR to CMS, and that they're taking more than 3 months. They never respond less than 30 days. I can tell you that I have heard this chatter as well. So if we can get an answer and a resolution to this, I think that this would be great for a lot of folks that are having this same issue.
I'm going to provide an answer. It's not going to be a day one resolution, but I'm going to acknowledge that the process is taking longer than anyone intended. We also have received far more disputes than we anticipated, the IDR entities anticipated. I think we averaged around 23,000 total annual disputes for the federal IDR process. As of the end of September, we were at 90,000 disputes. So there are a lot of disputes in the system, one. Two, a lot, especially in the beginning of the disputes that we received, there were a lot of questions about eligibility, things such as, does this belong in the state or the federal? Has the open negotiation process occurred? Is this batched right or bundled right? All of these issues are taking back and forth communications between both parties to gather information, to fact find, to figure out if the case is in the right place and if it's eligible for the federal IDR process. we acknowledge that it's complex, so we put out a lot of technical assistance. We've updated our system. I believe there's updates that are being released even today that are going to require more information to help determine some of these issues on the front end, so that once the IDR process is initiated and it gets to an IDR entity, they don't have to go back to a plan and say, hey, you said this process doesn't apply. Why do you think? Give me the information. Plans are going to be required to give that information on the front end. Same with payers. Providers, there's going to be information that we're going to ask for to help us figure out these eligibility issues up front. But in regards, and apologies, it's the kids are walking out the door for school and they just walked into my office. But with regards to the backlog, last week we did release a message on our website acknowledging that we have put additional workforce on this issue. We have a large amount of people who are going through the backlog. You may receive notification from our federal IDR team saying, hey, we're helping the IDREs gather this information to get through the backlog. This we need from you. And so I encourage you to look out for those emails and be responsive to those emails as quickly as possible. And we are like working all day and all night to get through this. So I just want to acknowledge that, you know, your dispute is not in a black hole somewhere. They are being worked. We have put additional resources on this, and hopefully soon the process will be working as intended and much smoother.
So Deborah and Nadine, I'd just like to comment first. Thank you for taking the time to do this. This was set up, the NSA was set up as a consumer patient protection. Because of this backlog, because of the numerous problems that we've seen, I think what Dr. Rahamian said is something that's happening with a lot of people. Myself as an anesthesiologist, we have 1,000 claims from January. Not one claim has made it through the federal IDR process yet. It's turning into a protection for the insurance companies. You know, they are the ones who are really getting the upper hand here, and the physicians are not getting payment. They're not making it through the process. In addition, with the lack of transparency to the QPA, there's no way for you to see whether these numbers that they're using are accurate and they're not using ghost rates or duplicates. So I would just urge you to please, you know, devote the resources that you've said. Please try and educate these claims, and please just try and, you know, work for the physicians as well, because this is really hurting our practices.
Okay. Actually, the meeting does end at 8:30. However, Aideen advised that her and her team would be willing to stay on to answer some additional questions. So if we want to move on to the next question, what is the general fee schedule that they do consider if they prohibit UNC? Right now, we seem to be reimbursed less than Medicare rates with these QPA rates.
So there's no general fee schedule that the IDR entities consider when they are making payment determinations. As you rightfully point out, there are statutory items that the IDR entities are prohibited, such as UNC and public reimbursement rates that they are not allowed to consider, and that's in the statute. However, when you are submitting a IDR offer, you can provide whatever documentation, whatever supporting evidence that's not one of the permissible rates. So not just the 5 or 6 factors that are listed in the statute and regs, but any other supporting documentation, as long as it's not on the list of prohibited factors that the IDR entity can consider. But there's no sort of standard schedule that they must consider or that they do consider in every circumstance.
Can you please give any examples of information that might be considered that would be submitted by the provider that would be relevant?
So an example would be, I'm just thinking through sort of what examples we provided in the reg related to a specific case. If the acuity of the specific case is beyond standard payment rates, you might provide an explanation as to why, or evidence of the extra care that was provided in that case that would garner a higher reimbursement or reimbursement that was higher than what was provided for the payment. The plans and insurers aren't required to reimburse on the QPA. So the allowable rate or the rate that you receive may not be the QPA. And so whatever evidence supporting sort of what you feel is the appropriate rate that's not on the list would be considered.
Does the statute, does it prohibit you from providing evidence of previous patients' allowed rates by the same provider or other providers for the same CPT code? So that's prohibited as a reference point.
With that same plan or issuer, it does not prohibit what the previous contracted rates would be with that plan or issuer. But are you asking specifically for that patient under a different plan?
The same CPT code, if you provide evidence of what the allowed rate was prior to 2022 as a reference point, is that prohibited as evidence for?
That is on the list of
that it's on the list.
Yeah.
Okay. All right. Thanks.
Okay, moving on to the next question. This is from Wilma, so this might be a repeat so just let me know. We are out of network with all commercial insurers and every patient signs a waiver. They are aware that we are out of network, so this is an exception to the Surprise Billing Act. We find that the insurances are still giving us a hard time processing the claim that patients are out of networks. How do we get to honor and reprocess the claims? I think we did discuss this, Wilma, so if you just want to, if you want to just go ahead and send me some of your repetitive issues with the companies, and I can reach out to my contacts and just provide them the claim numbers. And
I have one follow-up question that the doctor just addressed. So when I'm looking at, for example, I'm asking them to reprocess the claim with the out-of-network benefits. Sometimes they tell me they have, but then I have a claim, for example, for like 2021 with the same exact codes, and they're reprocessing it with out-of-network benefits, but they're still not paying the same amount they would have in 2021. And it's not considered surprise bill if there's a waiver. So how do I go about, I'm disputing it's telling them you're still not paying with out-of-network benefits, and they're saying that they are. And, you know, at that point, they already know that there is a waiver and the Surprise Act does not apply. So how can they argue that?
Send me that one.
Okay.
If it's one, I send it and I'll send it on. And if you've already gone back and forth, I mean, obviously for just, I want to make it very clear. I'm not, you need to do your part in your process before you bring to me. I'm not a shortcut to go to the insurance companies. I will fight for you. Absolutely. But I need you guys to do, you know, the processes and not use me as a shortcut to get things.
No, absolutely. I mean, I've been working for this case for a year, and I feel bad for the patient because he needs another surgery and he can't move on because they won't do what they're supposed to do. Like he said, they're protecting the insurances, not the patient themselves or the provider.
Right. So you send me that one, and I will just, you know, give me the dates when you did this, when you did that, and I can definitely follow up with the insurance company. And like I said, I will fight for you. I'll go through the whole date time and you know, make sure that the processes were followed and that we need to fight it. But then we'll go from there. Okay, and same, anybody else that's a MISNY member, my services are a part of your membership. So if you're not a member, and you should be a member, because that's this director of physician payment and practice, this is what I do. I go back and forth with the insurance companies and vet the claims before the issues before, and I'll throw this number out because I just happened to get the stats. Since January this year, I've had 560 consults, and I only have 42 that are unresolved to date. So I'm pretty successful with getting things turned around. And it does not happen overnight. I have a meeting today on something from January, but I will not stop fighting. I keep track of everything, and I continue to follow up. So please, if you're a MISNY member, reach out to me, use me. That's why I'm here. That's why I was hired. So please, definitely. Moving on to the next question. This is from Carolyn regarding the notice of IDR initiation. Some payers require their payer specific form of notice if it is administratively cumbersome and frustrating to do both. Is there any review by CMS being done to eliminate payers from having other forms? Also, if we do the payer form, is the CMS notice form required as well, or will having it compromise a provider's successful outcome in this process? Let me know if you want me to repeat that.
I can take that. I think I answered some of this already. The CMS form is required. It is a required standard form. And so I would encourage you to use that form because later in the process, if the plan makes a claim that the open negotiation process did not occur, the federal IDR team is going to ask you, okay, provider, where is your evidence? Show us your open negotiation form. So use the standard form. We are aware that plans are asking for additional forms. We have communicated to them that they cannot require more than what is required in the regs. They may request it of providers, and providers can respond and should respond to the extent that the information they are requesting will help them identify the claim and process your dispute more timely. But there is no statutory or regulatory requirement that you use the plan or insurance form.
Okay. This is Dr. Schulman. Most of us would know. Okay, we got that. Process seems to be about 115 days or so. What has been experienced thus far, and what is the physician's recourse if the process is not followed in the timeline? I think that did we address that? And I think that it was discussed that there were additional resources that have been added. Do we have a timeline, like on when we think that the turnaround is going to improve and not take so long?
Oh, I I do not have a
Okay.
timeline. Just know that people are.
Is there any way that we could get a report of if, what month they're on claim wise? Like if they're working on January, if they're working on February, if they're working, at least some kind of update as to where the additional resources have got, you know what I'm saying? Is there any way we could get some kind of report of that, Aideen?
Okay, Heather, say that again.
Is there any way with the additional resources that have been added to address the lag in the IDR process? Is there any opportunity for us to get like a report as to where they're at in processing these? Are they working on January accounts? Are they working on February accounts? Is there any way, like, is it done by Alpha by the patient's name, by the provider's name, just so that we know where they're at, where things are working at. So if somebody submitted something a month ago from, you know, an October claim or a September claim, what the expectation when they're going to start being reviewed. Do you know what I mean?
I understand.
Transparency wise.
I understand. Is there anyone from CSIO that can answer that, or maybe we can come back to her?
Yeah, I was gonna say, I'll take that back. It's a little, they are working oldest to newest, and it would probably vary by the IDR entity that we're working with. So that might be a little hard to produce, but I'll take that back to see.
Okay, yeah, that'd be great if we could just, you know, just to provide some transparency. I think that would be very helpful. You know, it was recognized that it's taking an additional time, resources were brought on, and this is the resources being brought on has escalated, you know, things to be worked on, and here's where we're at, what we're working on. I think that might just be helpful.
Right, and
Yeah.
you know, can I say something too? Because I hear the frustration here, and trust me, we are equally as frustrated in the backlog, and we have no allegiance to either. Our job is to protect the patients and establish a process that is efficient for everyone. You know, we hear from you all about the payers gaming the system and making it difficult. We recognize that the providers need payments as well. We also hear from the payers that they're just receiving hundreds of thousands of line items, many of which are Medicare or Medicaid, and it's taking them a long time to process them and identify what's not. And if they reach out to the providers, they're not getting information. So we hear from both sides the frustration in the process, and it's not, you know, it's likely not the providers on this call that are providing issuers for the payers, and the payers, there are some that are providing issuers from the providers. We are hearing it from both sides, and we are doing what we can very quickly to try to make this process smoother for everyone. So I want to acknowledge your frustration, and I want to ensure you that we hear you and that we are working to make this process smoother for everyone.
Deborah, thank you so much for those words. I'm sure a lot of people on this call really appreciate that. And I think that, you know, just providing the feedback on where things are at, and then, you know, moving that message forward so that others are aware that this is what's really happening. I mean, not for nothing, I'm sure we all can imagine, you know, if our paychecks didn't come in for 8 or 9 months, we'd probably feel a big pinch in that. So, and that's what it is for these guys. You know, we have businesses to run, and so when things don't come in, you know, 9 months, 10 months, that tends to create a significant burden. So, you know, thank you for recognizing that, Deborah. I really appreciate that. And if that can, you know, you guys can bring this stuff back to the team, and we can have that open communication. And, you know, even if you want to give it to the information to Aideen, and we can have it on our Tuesday night call. Every second Tuesday of the month, we have a CMS call that any physician can join this call and bring concerns, topics up. It's an open agenda, literally open agenda meeting that we have with Aideen and her team and Anthony. And so I welcome you to come to that, and hopefully I can provide some feedback to our members. So thank you again, Deborah, for your words. I really appreciate that.
And just while you're waiting, just some quick metrics you can provide, like there are like 15 or 20 federal IDR agencies, and the running number of outstanding claims is about 200,000, 500,000. Do you have any simple metrics?
So I think I said before, there's about as of September 30, we had 90,000 claims. There will be some more metrics published soon that provide more insight into sort of where we are in the process. I just cannot share them today.
And there are roughly how many federal IDRs? 10,
Yeah.
15, 20?
There are 13 certified. IDRs.
13 so far, okay.
Who certifies them, Deborah? Just one.
The department certified them.
Okay. Okay, let's move on to the next question. And you'll take that away to provide more information or with the other information that you're gonna
Oh,
bring?
yes, yes.
Okay, great.
there will
Awesome.
be more information.
Awesome. And okay, it's 8:45 and it looks like we have, here's another one from the prohibited factors seem to include everything except for the insurance companies in network rates. What other information is allowed to be submitted by the provider in the IDR process? Has that one been answered?
I think it has been answered. The provider,
By Dr. Deegan, if I'm saying that right. I'm sorry if I'm not. What defines or who determines emergency? For example, a minor laceration. Dr. Jeter. So the question is, what defines or who determines emergency? For example, a minor laceration. Is it, I mean, I guess is it when it is a revenue code, is an emergency room revenue code is what the determining factor on if it's emergency or not? How is that being determined? Is it a certain code? Is it certain CPT codes fall in that? Is it certain revenue codes? I guess how and who determines?
it's not like a certain list of revenue codes that determine whether it's an emergency or not emergency, but it is where and who provides the item or service, if it's a covered provider or facility, such as an emergency department. If that minor laceration happens there, that would be considered emergency item or service.
So do we know how it's being, so basically anything that's done in the emergency rooms. So I would say that's probably done based off of a revenue code of emergency room or point of service, right? Point of service, emergency room.
Heather,
Yep.
This is Troy. I work with Heather, and I know under New York law, at least, and I believe that there's similar federal rules. It's governed by the prudent layperson standard that, an emergency, at the end of the day, whether it actually is an emergency or not, is governed by whether a prudent layperson, an ordinary, reasonably prudent person would believe that there's a serious risk to their health if they don't get immediate medical care. And that can get disputed sometimes. So a minor laceration, is it an emergency or is it not, could be disputed, even if it's delivered in an emergency room.
Thank you, Troy.
Hi, this is Jean Ann. I just need to jump in. Deborah and Dara both have to drop for other calls, and they are true experts on this call. So I think what we should probably do is, Heather, if you can send us any additional questions.
Yeah.
And we can see what we can do about getting back to the group
Yeah.
on that.
We only had 2 more questions, so I will definitely send that out. And I will get that back to, I'll probably do the questions with the answers and provide it when we update the website and the slides, the webinar, excuse me, on the website. So, I'd like to thank Aideen and Jean Ann, so much for joining this call, the webinar and providing the information and answering the questions. I know that this is as Aideen, you and I have talked multiple times, this has been a really cloudy topic subject with a lot of our members creating a lot of frustration. And so I think that providing the level of transparencies of where we're at, what we're doing, how they need to next steps that they need to take when the appropriate steps are not being followed or it's taking a very long time. I think that that's definitely helpful to us. And I'm sure I'm going to have some work ahead of me with some claim numbers. I see I've got a bunch of emails already that came in, so I'll be busy with that. And Aideen, we can definitely follow up offline and just with some action plans from some of the questions. But again, thank you everyone for joining. I really appreciate it. This webinar is the webinar is being recorded and will be on our website. So if you want to go, as well as the slides, if you want to go and have a listen, or you want to send to somebody that wanted to hear the information that wasn't able to attend, please feel free to provide that information.
Heather, really quickly, sorry to interrupt. I did want to put in the chat, because we did not really get into the details of federal versus New York jurisdiction over payment disputes. So I did put that in the chat, and I'm happy to answer more questions later.
Okay, excellent. And if anyone has any questions, I put my email in the chat quite a couple of times. So please, if you have any questions that you would like me to bump up, please email that to me. Or if you would like to join our Tuesday call, email me and I can send the link. Every single second Tuesday of the month, we have an open agenda meeting with CMS that we talk about various things. So please, this is for MSNY members, and this has been started. We were going on, I think, 6 months now. So happy to have those conversations as well. And then again, thank you, Aideen and team, and you really appreciative of you guys taking the time, your expertise, your knowledge, and understanding and recognizing our frustration as MSNY. And we're really lucky to have the relationship that we have with you guys, to be able to just shoot an email, give a phone call, and have a discussion. So thank you again. And if anyone needs me, please email me. If you're not a MSNY member, I urge you to join. You can email me and I can get you in contact with the membership department. A lot of benefits that you can take advantage of by being a MSNY member. And thanks again, everybody. I hope you have a really great day. If I don't talk to you, happy holidays coming up. I hope you have a lovely time, safe time with your family and friends. So
thank you, Heather, and thank you everyone for joining us so early in the morning and staying. We will answer your questions that we have not had a chance to answer at this meeting. Thank you. Thank you.
Hi, Heather, are you still on?
yes, I'm on.
The bi-weekly chat with the CMS, do you want to share that link for some of us who may be interested?
Yeah, I definitely will. I'll put it in.
However you want to format it. I don't know if you want to put it on the website or you want us to request.
So I'm going to put it in the chat right now. We do,
Okay.
I do run it about a week prior in like MSNY Pulse. It doesn't require a registration. It's the same link every single month. So I'm going to just put it right here in the chat.
Okay, perfect.
Yeah, it's really, we're really lucky to have that, because when I started here, Anthony Gemrosi reached out to me and said, let's get something together. Let's do something. And I said, yeah, let's do it. So we came up with this idea, and it's literally an open agenda, and any MSNY member can hop on this call. We've actually tackled a couple of things you know, obviously some things that you bring, they're not going to be able to answer right away, but they definitely will look into it and provide transparency and answers. Might not be the answers that we want, but you know, at least there's that availability to have that open discussion. So.
Yeah, I think it's great that you have that link, because I represent the physicians at Mount Sinai. So when people have common issues, at least we can channel it to the CMS in a respectful manner. You know, I
Right.
think it's important we keep the channel very respectful.
Oh,
A
absolutely.
lot of people
I mean,
have
it needs to
anger,
be
but they can't
civil.
put it together in a coherent fashion to get some form of result or move the needle.
Yeah.
But you know, so I think I got the link. You just put it on.
Yeah.
You know, when we have certain issues, I can bring it to them and then take it back to my physician group rather than everyone
Yeah.
just complaining and getting no
Right.
no idea of getting some form of movement.
Right. And not only a
Yeah, so
CMS
I'll
on it, NGS is also, there's representation from NGS as well that's on it. Like one of the issues where
Okay, fine.
brought up was the dense breast issue in regards to Medicare's national coverage determination not covering a screening ultrasound if a woman has dense breasts. So that's one thing that we've been working on for quite a few months, and there's been multiple meetings on it. So we may be a part in changing that national coverage determination to best practices. So it's a really good
But
opportunity.
you have different meetings, or you put two of them on the same meeting? The CMS and NGS in the same meeting, you have separate meetings?
Same meeting.
Same meeting, okay.
It's that Tuesday
Right.
night. Yep. At 6 o'clock, second Tuesday of the month.
Okay, it's let me just make sure, it's on the thing, right? On the
Yep, I
the
just
time
sent.
is on,
Yep.
yeah.
6 o'clock. The link is on there. You can either join via Zoom or you can call in.
Okay, fine.
Yeah. It's a great opportunity.
Every
Second
second Tuesday, correct?
6 o'clock. Yep.
Okay, good. All right, thanks a lot.
Yeah. You're welcome. Have a good day.
Good seeing you again. Take care.
You
Bye.
as well. Take care.